For those that don't understand what a respiratory therapist does, can you describe what it means to be responsible for somebody's ability to breathe and essentially responsible for their life?
So I work with any age category from infant all the way through end of life, pediatrics, adults, all of it. Something as simple as giving an inhaler, or all the way to life support and end of life. So everything in between that, again, has anything to do with their heart or their lungs. I do a lot of really cool things. We do like bedside tracheostomies, bedside sternotomies. Sometimes we'll go into the OR. We get to be a part of those things. Yeah, you're kind of like looked at as you could either be the best thing they want to see or the Grim Reaper. So like at end of life, we are the ones that end up pulling the plug. Or, we're also the ones that will literally bring your loved one back to life and keep them alive. As long as you want us to, we will keep them alive.
Is there a story or a specific case of a patient that was one of the more rewarding ones that stick out to you?
More sad stories. But the one, she was young, early 20s, and she was pregnant. And I think she was having a miscarriage. And she was sitting on the toilet when she was miscarrying and lost so much blood that she fell and she hit her head on the sink. And it caused a traumatic brain injury and a severe, severe brain bleed. So this case, unfortunately, she ended up being a gift of life candidate to donate her organs. And I just remember doing like an honor walk for her and being able to be a part of that experience. I even got to stay in the OR, and given that she was, pronounced brain dead, she was still able to like give life. And that was really, really interesting. When we got to the OR, pretty much I asked if I could just stay and observe, and they said no problem. They gave me a step stool, and I was able to stand at the foot of the bed and observe the entire harvesting. They call it a harvesting because they're harvesting organs. But after you disconnect them from the ventilator, which is what I manage ventilators, they're like vultures. There's lots of egos going on in the OR, and who gets to go first? What organs go first? Who goes last? What organs are the most viable if they go last? And just the amount of blood that you see in a harvesting blows your mind. I had no idea that we know how much blood is in the body, but when you see it being like pulled out, sucked out of the body in these large canisters, the blood is being sucked out of the body so fast that it literally just looks like you're whipping tubes because it's just sucking the blood out so fast that the tubes are just whipping. And you're just like, it's chaos. It's absolute chaos in the OR when you're harvesting. But, kind of gives me chills because she was able to provide so much life for other people, but yet she wasn't able to have a life herself, And then there was another one that happened not even that long ago. She was like 9 months pregnant, and her boyfriend was driving the car, and there were drugs in the car. She was ready to go at any minute, and it was pouring rain outside, and it was the end of my shift. It was literally 7 p.m. Level 1 trauma got called, and I think they called it an OB level 1, and he crashed the car and then tried saying she was the one that was driving, and she slid under the front seat of the car, and they couldn't even find her because I think after she had slid out of the car, somehow she like projected out of the car, and I just remember her coming in. They call it a Lucas, so it straps around them and it does the compressions for them, and she was like fully pregnant, and the boyfriend just kept blaming her, and he was like fully coherent, and he was just blaming her. She was driving. She was the one that was doing drugs. And like we couldn't get him to shut up, and he was in the other trauma bay. It was horrible. And I just remember the next thing you know, so I'm at the head of the bed, She's already intubated. I'm managing the airway at the head of the bed. So I'm bagging the patient. And the next thing you know, people are slipping all over the floor because of the rain. But then there was like a lot of water out of nowhere. And people were slipping and sliding, lots and lots of blood. And the next thing you know, I just see a baby being tossed over my head. So they did an emergent C-section right there in the trauma bay. And I turn around as I'm bagging her, and they're doing like little compressions on this little baby. And I don't think there was a single dry tear in that, a dry eye in that trauma bay that day, because she ended up not surviving, and neither did the baby. And it was all his fault. So it's things like that that make me really, really passionate about what I do for a living, because I was so determined to help, because that's just not fair.
What do you feel is one of the biggest misconceptions about what you do, something that people really don't understand?
Most people don't even know what we are. Up until COVID, nobody knew what a respiratory therapist was or what we did. And then COVID happened, and they're like, oh, this is a really severe respiratory disease. And then they heard about respiratory therapists. They're the only ones that know about this. What do we do? Like, let's just lean in on them. And that's how people started learning what respiratory therapists were, and we started gaining more respect, and people now know who we are and what we do for a living, and that our jobs are really, really important. So during COVID, when you've got pulmonary doctors saying to you, do you know what you're doing? And you turn to them and you're like, no, do you know what you're doing? We're just kind of like, no, let's just wing it. Let's just see what happens. So unfortunately, COVID was like an experiment. And we learned very quickly what you should and shouldn't do. So that was very, very interesting, that whole experience. And we finally got the recognition we deserve. We were always the unsung heroes.
Do you feel that there's a kind of like a roadblock sometimes with just the whole medical system that kind of puts you in a position where maybe people are disappointed in you?
Yes, because the medical system is all about money. It's a business. And for years, everybody thought, like, we're here to help. We're here to improve lives. But at the end of the day, it all comes down to money. Something as simple as a medication that I know that my patient needs, and I make a suggestion for it, and I get pushback because of the cost of the drug. I don't care how much the drug costs. This is what they need. So at the end of the day, I only have so much say until I push and I push and I push. And I know that a lot of people in my field won't take those extra steps or go the extra mile that they should to get the patient the care that they need. So I just remind them, if this were you or if this were your loved one in that bed, what would you want? So you have to fight for it, because I also believe in karma.
There's been some pretty traumatic cases that you've worked on. How do you process that emotion, the emotional weight of doing that, and kind of what keeps you going?
It's actually a really good question. Unfortunately, when you work in medicine for so long, you do become slightly desensitized to certain things. But you can't let medicine completely desensitize you, because then you're not going to know how to empathize for people or how to put yourself in their shoes. The things that traumatize me the most are pediatrics, babies, infants. I have had babies die right in my hands. And that's really, really traumatizing. I've had teenagers that committed suicide, and, just seeing that, and then how their parents respond to having to identify them right there in the trauma bay is horrible. Like hearing a mother's wailing cries. It's like the sound you'll never forget. So things like that, you can't forget sounds of the cries of parents when they lose a child. That's probably the hardest part of my job.